glibenclamide, and metformin is used in first trimester in PCOD patients, and they fare very good with metformin. Thank you.
Thank you, Dr. Vatsali. It was a controversial issue, and let's see what our speaker's take is there on it. The last of our panelists is Dr. Rahul Jain, and he'll be speaking on insulin analog vis-a-vis conventional insulin, his take on it, as far as management of GDF is concerned.
First of all, a very good morning to all present in the auditorium. Special thanks to Dr. Parni for inviting me to share my views. Yes, very controversial when the talk of using any oral hypoglycemic agent, or for that matter insulin also in gestational diabetes, this subject crops up. The reason why it's very difficult to set, give guidelines is, as per the Vancouver Declaration, doing any studies, getting ethical clearance for this intervention versus that intervention becomes very difficult because of the very strong overriding ethical issues related to human pregnancy and childhood, and the effect of the fetus, the drugs on the fetus, and how it might or might not hamper the livelihood of the fetus later on. So it's a very controversial area as far as oral hypoglycemic agents are concerned. But I will not exceed my brief. I have been asked to speak on conventional vis-a-vis analog insulins. Now, if you look at the various guidelines, very recently we had the JAPI issue, I believe in 2014 itself, where a co-writing group of several very eminent experts, Dr. Sheshaiah, Dr. Balaji from our city, Dr. Shomur Banerjee, Professor Shomur Banerjee. So if you go by the various guidelines, there seems to emerge a clear benefit of using analog insulins over the conventional regular insulins. That is, if cost is not a factor. The reason why now analog insulins, of course, the short-acting analogs in the form of Lispro and Aspart. I'm not talking about glulicin, which is not recommended, and the long-acting analogs. I'll talk about them. If you look at the short-acting analogs, basically to cover the postprandial glucose excursions, you need an insulin which is going to act immediately, quickly. The duration of the peak of action will be as soon as the glucose peaks in the body and fall as rapidly as the post-meal, just to cover the duration of the prandial hyperglycemia. I think analog insulins, especially Lispro and Aspart, have proven superiority, because if you use regular insulins, then you have to give it half an hour earlier, and the duration of action, the peak of action is later, and the duration of action is longer. As we know, in diabetes, it becomes very difficult, especially in the first trimester. I think the gynecologist will agree. Many times the patient might take insulin and vomit. Vomiting in the first trimester, sometimes it can continue up to the middle of the second trimester. It becomes very difficult. The patient has taken insulin, half an hour later supposed to eat, and suddenly says, I don't want to eat. So you get greater flexibility because these analog insulins, Lispro and Aspart, are given just before, and though I do not recommend them to be given after meal, in certain very, very fussy eaters, you're not very sure whether they might or might not eat, perhaps even just after a meal. The analog insulins can be given. The peak of action is much faster, duration of action is much shorter, say only 4 hours, 5 hours, and so you end up getting less of these post-absorptive hypoglycemic crises. And most importantly here is the US FDA has given a category B to both Lispro and Aspart, so it can be used very safely. The evidence is quite robust, not although very strong, but quite robust. You may use them in your gestational diabetes and pre-gestational diabetes patients. As far as long-acting analog is concerned, we have number of long-acting analogs. Now, NPH can be given twice a day, or you can give one of the different analogs. Now, different organizations have different takes. Detamir is emerging as the consensus analog to be used in gestational diabetes. The Endocrine Society has even said that a person lady who's continuing on glargine may continue to do throughout her pregnancy, although it's not recommended by many august bodies because of the high IGF-1 binding. So we don't want any teratogenicity, but there's very little evidence that glargine is mutagenic or teratogenic, but still it's an agent which is best avoided. Detamir is the agent of choice, along with NPH, of course. In fact, the Endocrine Society also recommends that even if you think the patient might go into hypoglycemia because of the very subtle peak of the NPH, you can use Detamir. But the other analog which is available, that is Degludec, is not to be used at all. So I think in my practice, if you ask my personal views, the short-acting analogs just before meals, Lispro and Aspart, are quite good agents and quite useful because of short duration of action, hit and run phenomenon. They will act and they will vanish from the bloodstream. And if long-acting vis-a-vis NPH, I think Detamir in my practice has given me better results with more predictability and less chance of nocturnal hypoglycemias. I use these agents very, very frequently. So, I mean, but of course, if cost is a factor, then half an hour previously, regular insulin and twice a day NPH, or sometimes split mix regime as some people use, is not a bad agent at all. Thank you.
Thank you, Dr. Jain. His state is towards insulin analog. And obviously, we are going to take all the issues seriously when the speakers are going to speak. So, a big round of applause for the panelists. They really deserve it. They have done it. Thanks a lot, all of you.
Well, thank you very much, sir. Now I would like to request you for the tea break before we start off all the scientific sessions. Kindly join us outside for the tea break being served. Thank you.
Okay, after the tea break. Now we are starting the main session of the afternoon. That's the speakers program on GDM. I'll be inviting the speakers for a small introduction. So, on the podium, may I invite Dr. Anuj Maheshwari on the podium. Yeah, please come. Yeah, Dr. S. Nella Perumal, please. Dr. Anand Sankar, Dr. Anirban Sinha, and Dr. Barnali Ghosh. It's my privilege that all our speakers, eminent part of India, has graced this occasion. We are going to felicitate them with a bouquet. Anvesha, can you do the needful, please? It's okay. Dr. Barnali goes, a big clap for her. Dr. S. Nalla Perumal from Chennai. Dr. Anuj Maheshwari from Lucknow. Dr. Anand Sankar from Patna. And our own member, Dr. Anirban Sinha. Everyone knows him now. I once again thank all the speakers for coming here. And now we are going to start the speakers program. The first speaker will be Dr. Anuj Maheshwari. Dr. Maheshwari is a diabetologist and metabolic physician, professor and the head in internal medicine, BPD CODS, BPD University, Lucknow. He is the organizing secretary of next year's RSSDI. He Chapter Secretary RSSDI UP Chapter, the Regional Faculty CCGDM, Core Committee Member and Faculty for Specialty Course on GDM, by DIPSI and FOG-SI, and is a national faculty in RSSDA as well. He was the organizing secretary Diabetes India Regional Update 2014 at Srinagar, and is the National Advisory Board Member DIPSI. So I welcome Dr. Anish Maheshwari, and he's going to speak on GDM overview of various guidelines. Thank you. Take your seat.
Thank you, Dr. Patni, and thank you by DRWA to inviting me here to interact with you on various aspects of the gestational diabetes. It was a wonderful session in the morning when we interacted with the experts of Kolkata about the various aspects of GDM in panel discussion. And in fact, I should like to take a call from that panel discussion only. There are a lot of controversies in the management of gestational diabetes, and those controversies starts very much from the guidelines. What to follow, what should be the cutoff, what should be the cutoff for the management, what should be the cutoff for the diagnosis, what should be the options for the management. So there are a lot of controversial issues. So I shall start it from the legacy effect of the gestational diabetes. We all know that one of the speakers in the panel discussion has said that gestational diabetes is simply a imbalance of maternal fuels, probably overproduction and underutilization of the fuels, and very important fuel of those is glucose. And this particular glucose alters the fetal islet functions by providing and as an end result of that, we come to see childhood obesity, macrosomia, and later on. These fetal islets starts working, in fact overworking since in the pregnancy too. So the chances of impaired glucose tolerance by the age of puberty very high. And this particular thing leads to the impaired adult islet function, and person becomes more prone to develop diabetes, and many a time it reflects in the form of the gestational diabetes when there is a burden of the pregnancy and lot of hormones work against the insulin too. So for that reason, a universal testing for glucose has been recommended in the high prevalence of type 2 diabetes population. And it is very much important in Indian perspective too, because Indian women are 11-fold more prone to develop diabetes in pregnancy as compared to their Caucasian counterparts. And in the ethnic group in the South Asian countries also, Indian women have got the highest frequency of gestational diabetes. So it is very much important that if we are dealing with the Indian population, universal testing for glucose is recommended. But this is not an easy thing for a country like poor resources of ours. Because in most of the time, so all women should be screened for gestational diabetes even if they have no symptoms according to new recommendations. So these are the final recommendations, and these recommendations has also been adopted by DIPSI also, that all women should be screened for the diagnosis for the diabetes even if they have no symptom, no previous history, nothing like that which can make them more prone to develop diabetes, but they should be asked to get their test for diabetes screened. For this, how should this test will be done? Lot of guidelines, lot of recommendations are roaming around in the world. WHO, NICE guidelines, one of the speakers has given an idea of the NICE guidelines also. ADA, IADPSC. WHO says fasting plasma glucose is really not required. Only 2 hours 75 gram glucose load glucose measurement, plasma glucose measurement is enough, and cutoff should be the 140. NICE guidelines comes in a bit different. Although they support the WHO guidelines in the postprandial hyperglycemia after the 75 gram oral glucose load, but they say they give the liberty to go up to the 126 for the diagnosis of gestational diabetes in the fasting state. ADA, which is the highly followed by the people in the world, says, and nice guideline says, that any one value of these two is enough for the making of gestational diabetes diagnosis. Now come over to the ADA. ADA says you should measure fasting plasma glucose, you should measure after 1 hour of the 75 gram glucose, and then you should measure the 2 hour after the 75 gram of the glucose. And it should be 95 cutoff for the fasting, 180 for the 1 hour post glucose 75 gram, and after 2 hours of the 75 gram glucose, it should be 155 or less. And ADA says that any two values are really required to make the diagnosis. And that makes it more difficult to follow, because then you will have to do all the three measurements in one patient, and many times it becomes difficult in the poor resources country. At the same time, when the people are not so much knowledgeable, they do not turn up for the fasting plasma glucose next day or for the 1 hour and 2 hours, so many breaks. And many of the people also object for the 75 gram oral glucose also. They say after giving the glucose, they have got increased our glucose. So it is also very much required to make them understand that giving the glucose is not going to make you diabetic, because if you are non-diabetic, then you will not have any impact of the taking of this glucose. This is also important to make them understand. IAD-PSC. IAD-PSC is an organization. This is International Association of Diabetes in Pregnancy Study Groups throughout the world. It has almost followed the ADA, or you can say that it has refined the ADA guidelines. It says that fasting plasma glucose is required to be maximum up to 92 milligram per deciliter. After 1 hour of the 75 gram glucose, it should not be more than 180, and 2 hours it says 153, which is almost like the ADA. But very important thing, the IAD-PSC recommends that any one of this is enough to make the diagnosis of gestational diabetes. So here, important thing is that 75 gram OGTT performed in pregnancy uses the same threshold of 2 hour post-glucose more than 140 milligram per deciliter, similar to that of the impaired glucose tolerance outside the pregnancy. Outside the pregnancy, the people, those who are not pregnant, in females, those who are not pregnant, we take the criteria of more than 140 as a impaired glucose tolerance. What is the same criteria taken in the pregnancy for the diagnosis of GDM? But 2 hour OGTT, an estimation of the fasting 1 hour and 2 hour glucose level is necessary as per the IAD-PSC guidelines. And they also say that center to center differences occur in gestational diabetes frequency. Very important thing is there to understand that IAD-PSC is looking forward throughout the world. So they have to take under the consideration of throughout the world, including America, including the highly resourceful country, including the low resourceful country, including the countries which are having the high prevalence of gestational diabetes, as well as the countries those who are having low prevalence of that. So center to center the things will be different. And relative importance of the diagnosing by fasting 1 hour and 2 hour glucose will be different and throughout the world. So this may impact the strategies which should be used for the diagnosis of gestational diabetes as well as for the treatment of gestational diabetes. But what should be in the India? So again, the IAD-PSC criteria does not fit to our own requirement, because a cost utility analysis found that screening based IAD-PSC criteria are not cost effective. The screening strategy based on the IAD-PSC criteria may be cost effective only for the high resource settings, but probably is too costly for most countries including India. Cost effectiveness and availability of resources must also be considered in decisions related to the selection of criteria for local implementation, and this last thing is very much important as far as our country is concerned. So global differentials in human development makes it different recommendations for different parts of the world, and performing OGTT, fasting 1 hour and 2 hours may not be feasible in less resourceful countries, especially for going the 3 tests together. So need for a simple test, easy to perform, which is economical as well as evidence-based too. So all these requirements should be fulfilled, and DIPSI has really worked in that direction to find the necessities of the Indian population. The practical problem in diagnosing GDM, what comes to us, that most of the time pregnant women do not turn up next day for the fasting plasma glucose. Dropout rate is very high when pregnant is asked to come again for the glucose tolerance test. And attending the first prenatal visit in fasting state is impractical in many settings, and even a fasting blood test in antenatal booking is not found to be convenient in United Kingdom too. So a study has been planned in which prospectively 1,106 pregnant women has been given 75 gram glucose, and they has been tested for the plasma glucose after 2 hours of this glucose in the fasting state as well as in the non-fasting state too. In the earlier they were given in the non-fasting state, and after 72 hours of that they have been offered 75 gram glucose in the fasting state. And both the groups has been compared as far as their result of the diagnosis of gestational diabetes is concerned. And conclusion was that 2 hour post glucose more than 140 equal to or more than 140 milligram per deciliter with 75 gram oral glucose administered in pregnant women in the fasting or non-fasting state without regard to the time of the last meal is able to identify women with GDM. So without regard to the time of the last meal, testing is always very much convenient because you do not have to tell your patient to come again for the screening test or for the diagnostic test. It's very simple rationale is there. If you are taking so much of the glucose, even you are taking the high calorie diet, high carbohydrate diet, and you are non-diabetic, it is not going to impact your glycemic profile. Because as much as you are taking the glucose, the pancreas is able to secrete that much of the insulin to counteract that. But only in the patient, those who are GDM, those who are compromising with their insulin secretions from the pancreas, they may not get this advantage and they will be found with a hyperglycemic level. This cascading effect is advantageous as this would not result in the false positive diagnosis of gestational diabetes. Therefore, performing a single test procedure in the fasting or non-fasting state, irrespective of the last meal timing, is rational as the glucose concentration during the glucose tolerance test will be affected least by the time since the last meal in normal glucose tolerant women, but it will be affected by in the women those who are suffering with the GDM, and they will be diagnosed there. In non-pregnant adults, glycemic level in relation to meal has also been found to be not affected by the how much glucose or how much amount of the glucose challenge has been given. Advantage of the single step procedure with a single glucose value of 2 hour post glucose more than or equal to 140 milligram per deciliter is there. Pregnant women need not be fasting. It causes least disturbance in a pregnant woman's routine activities and serves as both screening and diagnostic procedures. But now a question arises, why 2 hours post glucose? Why not 1.5 hours? Why not 3 hours? Why not 1 hour? Now we shall try to find out the answer of these questions also. Most of the studies has correlated the outcome of the pregnancy with the 2 hour glucose. But when in relation to the third trimester 2 hour post glucose, plasma glucose has been found to be shown that macrosomia has been found to be the 8% if plasma glucose was 120 or more than 120 at 2 hours of the 75 gram glucose. But it has jumped to the 15%. It has jumped to the 15% if it could be maintained at 140 milligram per deciliter. So when this much of the change from 120 to 140 is giving the twice increase in the incidences of macrosomia, you can understand or you can have an idea what shall happen to the target of the 153. So definitely the target of keeping the post glucose 75 gram glucose plasma glucose is 153 is going to be disastrous in gestational diabetes, especially in our population. If we compare the forthcoming child developing the diabetes at 24 years of the age, here we have seen that 30%. If the population is keeping, if the mother is keeping her blood glucose level in the pregnancy 140 or more than this, 30% of those offsprings at 24 years of their age are going to develop type 2 diabetes. If that lady is maintaining her blood glucose level after 75 gram glucose, more than 200 or around 200, about more than 51% children, those who are coming up, will develop type 2 diabetes at the age of 24 years. So this is in fact going to be a source of diabetic population in our country. This is a very famous bronchocyte. It says that when you are reaching to the 140 milligram per deciliter of the blood glucose level, you are already lost with 1/3 of the beta cell function. And when it is really between in the 180 to 200 here, it is almost 85% of the beta cell function is lost. So same thing in the gestational diabetes. In the gestational diabetes also, if we are keeping our target at the 140, if the lady is having 140 or more than that, definitely it is going